Hello, ladies and gentlemen, colleagues. Thank you very much. I just want to say thank you very much for squeezing in, coming here in a very busy working day. It's really important, quite obviously, that NHS England hear clearly from us, all of us here in this room today, about our views on the consultation. You know more than anybody else what it will mean to our current patients and our future patients. And all I wanted to say, really on behalf of the board, I think, is that we're really clear. This isn't for us an argument. We're not trying to be NIMBYs. It's not about NIMBYism at all. It's about a very clear view that we want to make sure that our current patients and our future patients have the best possible outcomes. We're very proud of what we've achieved here at the moment with those outcomes. We don't want to see that change in the future. We want to do even better. And it's in that context that we welcome today's conversation.
Thank you, Sally. For those of you who don't know me, I'm Robert Craig. I'm the Chief Operating Officer. I've just got a few housekeeping things that I have to say. And then I'll let our colleagues introduce themselves and start the session. It's intended largely to be a question and answer session, though, so do ask your questions, and we've got about an hour till 1:30. The housekeeping things are that the fire exits are 3. There are 2 at the back the way you came in, and there's 1 down here at the front, and if there's an alarm, it's real. The other thing is that partly because this is the best time and venue we could come up with at relatively short notice, but it's not ideal for everybody. It's the middle of a busy working day, as Sally was saying. There are some issues about people not being able to come over here in scrubs, and therefore time for changing and so on, which just doesn't make it easy. And we know there are people who aren't here today who are otherwise would want to be. So we are recording this session, both sound and I dread, sadly for me, vision. So I'll be off camera in a moment. But therefore, please wait if you've got a question until the microphone is given to you. Otherwise, your question won't be captured and the answer might be, and it'll be a bit confusing. So sorry about that artificiality, but that's the way we'll get it available via the internet to as many people as needed. That's, I think, all I want to say by way of housekeeping. I'll hand over to our colleagues from NHS England. Will.
Thanks, Robert. Hi. For those of you who don't know me, I'm Will Huxter. I'm the Regional Director of Specialised Commissioning for London for NHS England, and I'm the National SRO for NHS England for the congenital heart disease work.
Hi, and I'm Sue Sawyer, and I'm the London Regional Programme of Care Lead for Internal Medicine for Specialised Commissioning, and I'm also the Lead Commissioner for this organisation. So I work very closely with the Trust on operational and commissioning aspects.
Okay. So I was really just going to say very few words before we get into the Q&A, because the real purpose of this, as Sally and Robert have both said, is a chance for staff here at the Brompton to ask questions, make comments. You'll all be very familiar with the proposals that are set out in our consultation document. This session today is one of a series of meetings, including a public meeting in Coin Street, which a number of people I know in the audience were at. We also, unfortunately, we had to rearrange things for the Overview and Scrutiny Committee in Kensington and Chelsea last week, but we will be going to that in May, as well as discussions that we're continuing to have with the Trust. So this is an opportunity that I really encourage you to use to raise your questions and comments. We are really clear that this is a consultation about our proposals. We want to hear responses. It's really key, both today that people raise things, but also that individuals as well as the organisation take the opportunity to feed back formally as part of the consultation, the details of which I know are widely circulated. And I know we've already had quite high numbers of people responding, which is great. So rather than I go through any of the detail of the proposals, as I say, because people here will be very familiar with them, I'm really happy just to open up to questions from the start.
So perhaps just a hand is down here, Mark, if you will. A couple of questions.
Hi, Will. Hi, Sue. Thanks for coming and giving us this opportunity today. It would seem to me the crux of the matter here is that you perceive our service is lacking around colocation. And I just wondered if you could be very specific and tell us what you think our patients are lacking. Our model is that, of course, that we have paediatric, general surgery and gastro with consultants and staff based down at Chelsea West, and they come up the road and see our patients here, whereas other models, it's on the same site. And we're just mystified to know exactly what it is you think our patients are lacking. And you feel so strongly about it that you would want to close a very large, successful congenital heart disease service just on that point.
Okay, so probably worth noting at this stage. So the standards, which include the standards about colocation, people know were agreed at the board by NHS England in July 2015. My role, I came to this after the standards had been agreed. So my role, my brief, is around implementing the standards. So while I know there was lots of debate about the specifics of what was in the standards and what they meant, what you're describing, Jan, is a service that is compliant with the April 2016 standard, which is 30-minute response, and I know that that's well documented in terms of audit and other things that have been done here. The standard, however, is to have that co-location where those services are based together on the same site. So that is the standard that, as has been well rehearsed, we consider the Trust doesn't meet. The proposal we're making is as a consequence of that, as you rightly say, to decommission the Level 1 service from...
But you are choosing to implement the standards in a certain way. Even during the provider group sessions, those standards were not so clearly cut, in that we were discussing, could we provide networks where various other dependencies could be located within the network. So you are, although you say the standards are set by professionals and we shouldn't be questioning them, it's your interpretation of the standards that we are questioning.
Okay.
And you must feel very strongly if you want to close a very successful large unit just for that one thing. What is it? What is it specifically that you think our patients are not getting?
I suppose just perhaps to re-emphasise the point, the standards that were agreed are really clear about the implementation timetable and process around that. We've been through quite a detailed process with the Brompton and with all other providers on their assessment against it. We're making proposals based on where providers are against those standards across the country. The deficit is that you haven't shared with us a plan that shows how you would meet the paediatric co-location. It's not about a feeling of how
so
strongly...
you can't actually tell me what aspect of care our patients are lacking.
The standard that isn't being met. So this is about... If I go back to...
I mean, there are other units who also don't have same-site co-located gastroenterology, Evelina, for one, and Newcastle, but you have said, well, okay, we'll work with those units rather than close them. So why the difference?
So the requirement that Evelina meets and that this Trust doesn't is the paediatric co-location. So
it doesn't meet co-location though, does it? Because its gastro services are based at King's, which is 4 kilometres away. It's a hell of a long distance compared with Chelsea West, which I can walk to in 3-4 minutes.
We've been through a process of looking at all of the providers as part of our final decision making. As through the board of NHS England, we'll make a decision based on looking in the at the detail of provision on all of those services. What I've said a couple of times is that we are proposing to do this on the basis of the information we've got at the moment and the impact assessment and information we've received from the Brompton and other providers. Part of what we're asking for response to is, do providers and patients and staff feel there are other ways in which we could address this? That's one of the specific things we're looking for as part of the consultation. So we'd welcome those views. I know I sense some frustration about how I'm describing it, but the reality is what we're judging against is those standards. And it's
but
quite...
Will, you're an intelligent human being, and you wouldn't be where you were if you didn't have, you weren't intelligent. And you know, the people at NHS England, both of you know very well about how medicine can be applied to patients. You're not naive. So you must think, surely you must think when you're interpreting those standards. And you must believe that this is such a strong factor that you're going to potentially close everything else that is really good at huge expense for that one thing. Do you not think you might question it?
So the proposals that have been made and that are reflected in the consultation document are based not just on the view of people such as myself, they're based on clinical advice we've received, including input from the clinical reference group and from other clinical representation to regional and national level that was prior to the proposals going forward. So it's not about me as a manager taking that view, it's about the combined view of the national panel.
Mr. Huxter, my name is Lee Settier. I'm a cardiac surgeon here at this trust. I'm sorry I wasn't able to be at the Coin Street meeting, but hearing your answers to Dr. Till, I get the impression that you're obfuscating. Huon Gray stated at the meeting, and I saw the video, that there was no evidence that the outcomes as provided by this trust, or indeed any other trust undertaking paediatric and congenital cardiac surgery, are in any way deficient as measured by international standards. He acknowledged that there was no evidence, therefore, on which to make some of the moves that you're suggesting. I want to know from you whether what you're engaged in at the moment is a charade. I want to know what the cost of this charade is and how you justify the waste of public money, not only in the process of this exercise, but all the other activities that have had to be undertaken in order to provide you with the massive amounts of data on which you appear to be moving in a fallacious direction.
So I recall the discussion with Hugh on that meeting. He was asked whether there was outcomes data, as you say, that demonstrated that paediatric colocation had a demonstrable impact on clinical outcomes, and Huon was very straightforward in saying there isn't the scientific evidence. As a scientist, he would like to be able to see of that. What he did say, though, was that the clinical consensus around the delivery of specialist paediatric services was that paediatric colocation was beneficial. So I don't accept that he said there was no basis on which for us to look at proposals for change. In terms of your question about being a charade, I absolutely disagree with that. This is an open public consultation. I wouldn't be coming to this meeting and a range of other meetings in London and more widely if I didn't want to hear people's views, hear people's comments, and for us to take a view from that. In terms of asking about the cost, in terms of the cost of the consultation exercise, I'm not sure if we've calculated that. I'm very happy for us to go back and look at that. In terms of the point about the impact on providers, I absolutely accept we've asked a lot of information on providers. One of the things that is true is that we got a lot of information from the Brompton after we gave our initial minded to decision and circulated that to the trust. It had taken us some time to get to the point of getting that information. So there's a bit about how we work together, but I accept there's been an impact on the trust and staff within the trust to generate that information. But when we are looking for evidence from providers about their meeting standards, that is part of what we do in this service and in others.
Well, you still haven't really justified the wastage or potential wastage of public funds at a time when the NHS is cash-strapped. And I put it to you that the outcomes in congenital heart surgery, particularly in an institution that promotes development, research and innovation in the way that this trust does, is of such a standard that it is really very invidious that you should sit here explaining why you think it is appropriate to close elements or all of our service.
There and then Marguerite after that.
Thank you. I'm Jolene Carvalho. I'm a phytocardiologist here at the Brompton. I have been here for a long, long time. Thank you for coming and for attempting to answer our questions. And with due respect, the first question has not yet been answered. Dr. Teal asked specifically what we failed, and I have not heard a reply to that. The reply I heard was, you're not here to question the standards, you're here to implement the standards. So my question to you, after possibly answering Dr. Teal's question, is why you choose to implement one standard for the Brompton and the same standard is not used to be implemented for closing another trust, colocation, as quite rightly said. Evelina doesn't have it on the same trust, on the same site. Why is that standard being used as an excuse to close the Brompton, but it's the same standard is not being used against other trusts?
So we are looking at the same standards for every trust. Our assessments are against the same standards. We've published on our website those assessments, and we've also published the impact assessments which have been highlighted by the trust. So we have sought to be extremely transparent about what we're doing. What we are setting out here is, what we're setting out in the consultation document is our set of proposals about what we would do. As I've said, we welcome comments and suggestions about how we could achieve the standards in the best possible way, but implementing the standards is not something that's negotiable. That's something that we wish to see happen. So back to the point about deficiency, I've said in public meetings about the Brompton and about other providers that we don't have concerns about outcomes. Indeed, they're very good across the country. In fact, in terms of congenital heart disease at the moment, the debate that Huon and others were highlighting at the Coin Street meeting is about how we make sure that services are sustainable in terms of practice into the future. And our view is that that set of standards in the round are ones that describe a service that will be sustainable for adults and children into the future.
I said Dr. Bannister next, and then we'll come to Michael.
Thank you. Hello, my name is Marguerite Bannister, and I'm a cardiac intensive care specialist. I have been for 15 years. And I want to ask how you can claim that colocation has clinical support. Personally, I find it astonishing that colocation of something like gastroenterology has such emphasis. I would have thought from my experience that something like colocation of cardiothoracic surgeons is something that every clinician, nurse and parent would want to have with their child if they are going to have or have had cardiothoracic surgery. And this is something that's echoed amongst all the clinicians that I know that are involved in my sphere, nationally, regionally and internationally. So I find it astonishing that you can claim that colocation has clinical support. You know, and we know, that from meeting minutes available online, that the clinicians group consulted when the standards were formulated did not consider the colocation of paediatric services to be either essential or preferable to the colocation of child and adult services. This was established, and this is common sense. Yet these views were later overruled, and we've discussed this before at Coin Street, by the board task and finish group, none of whom have experience working within the kind of vertical care model run here at the Royal Brompton, and most of whom, including Professor Gray, who are not even congenital specialists, people who are not specialists in this area. This is a highly specialised area. And as I said at the time, I would be ashamed, seriously, about what's going to happen to children. Why are children being treated in this way? Children with congenital heart disease that we do so well with, and as I said then, we are the place to go to if they have nowhere else to go to. So how can you say that this standard has the support of medical professionals who understand what we do? not medical professionals who are in a different sphere, who are in this highly specialised subject, when the truth is that the only relatively narrow view of a small number of clinicians who don't know what we're doing and cannot understand it because they don't do it, backed it, and the rest were overruled.
So, obviously I wasn't privy to the detail of those discussions. All I can say is that we did go out to public consultation on the standards. We got comments from clinicians in the field and from many others. So in deciding to agree the standards as they are described, the board took into account the feedback from that consultation, which was, I accept, not solely from clinicians working in the field, from a broader range of people.
I don't think that really answered the question.
Well, I'm sorry if you feel it doesn't answer the question. In terms of the clinical consensus in terms of specialist paediatric services, which is what we're talking about in this area, the point that Huon made at the Coin Street event, you'll recall, was that there's consensus that the delivery of that in services which bring colocation and paediatric specialties is the way that services are being developed and delivered in many parts of the world, including in this country.
So it hasn't answered the question. And when my 10-year-old daughter says, "Mummy, why are they closing you down because you haven't got gastroenterology on site? What is gastroenterology?" I said, "It's tummy stuff." And she said, "But don't you work in a cardiac unit? Isn't that to do with the heart?" I'm sorry, it's so common sense. I have nothing else to say.
And sorry, can we pass it across to Professor Gatsulis, and then I'll come to Richard and then Anne.
Thank you, Robert. I would like to deviate for a moment or two from the standards and talk about research and education. I speak here with my heart as the academic head of adult congenital heart disease and pulmonary arterial hypertension. For the latter, we have received for the last 10 years national designation in the setting of congenital heart disease. You may or may not be aware that we run the largest research program in the world in adult congenital heart disease, and probably the largest or second largest training program for adult congenital heart disease in the world. More than 50% of practicing consultant colleagues in this field train with us. We have trained more than 150 consultant colleagues or professors who practice adult congenital heart disease in the world over the past 15 to 20 years. Our research program is clinical. It's not lab-based. Our research has immediate implications on patient care. I can give you multiple examples of this, how our work here at the Brompton has transformed patient care in the United Kingdom and the rest of the world. Your contemplation of closing congenital heart disease here clearly would have a major impact in this important research and educational activity with immediate effect on patient care. It has been suggested that if you close down the congenital heart service at the Brompton, that these services, clinical, research and educational, can be relocated elsewhere. This is clearly a folly. How do these services develop? There are a number of factors. There are individuals and teams. It's the vertical model of care that many other places around the world aspire to, for obvious reasons. I don't need to expand to this. It's the interaction between pediatric and adult medicine, the integrated physiology labs, the patients themselves who are very willing to support us in clinical research because they themselves can see the benefits that they receive from it. These 10 years have been very damaging for the United Kingdom. For the little that we have, I agree with Professor Seth here that congenital cardiac surgery in the United Kingdom and services is a success story. There is no reason for this review. There is no reason, and it would be very damaging what you're suggesting, to close down the Brompton. And I can tell you that during these 10 years, we had a lot of expertise lost, recruitment has been difficult, and as we speak, senior members of the team are headhunted from units over the world. So my question to you is, would you now accept that closing the congenital heart services at the Brompton will have an adverse impact on research and education, which in itself has an immediate, current and future impact on patient care that you claim that you're going to improve according to these standards?
Absolutely acknowledge the huge scale and importance of the research and education work that's done here, and it was expressed very clearly as part of the Trust's response around the impact of our proposal, so it was very clearly set out. It's one of the things that we need to take into account in NHS England finally making its decisions about the proposals. I absolutely accept there's a link between research work and clinical practice. I take your point as well about uncertainty. I suppose the only point I'd add to that is that uncertainty has continued for a considerable period of time. Part of the purpose of the review, and it's a theme through previous reviews as well, is that we need to bring that uncertainty to an end. The only other point that I'd make is that, as we've discussed quite extensively, the challenge, the standard which at the moment the Trust hasn't demonstrated it meets is around paediatric colocation. One of the proposals, however, it's made, and I completely accept it may not be attractive for the Trust, but one of the proposals made is that the Trust could continue to be a level 1 adult centre linked to an alternative provision of paediatric services. So while I'm not disputing the importance of the research that happens, one of the options is to look at retaining adult services here.
This is the contemplation of closing the Royal Brompton, the congenital heart services here, is actually scandalous. You're contemplating of closing down a British flagship institution with an international role in research and education and excellent clinical care for no clear reason. As for the standards, whatever their value is, but you don't take into account this, and this is clearly scandalous. And I agree again with the discussion about the NHS and multiple needs and challenges. You should not be wasting time with this. You should find a different job to do. Thank you.
Well, Richard Grocott-Mason, Medical Director. A couple of points in the question. When NHS England board approved the standards, they were not discussed in the context of closing units. They were discussed in the context of developing networks. There was no discussion about the closing of units at that time. A lot of people in at this hospital, we've tried very carefully and very strongly to tell you the risk that we think that your proposals will damage the care of patients with congenital heart disease, and the big risk you've just heard from Professor Gatsoulis there, another demonstration of that. You obviously think that we're wrong. Perhaps you could tell us what risk assessment NHS England have done. You're proposing that we disperse patients to about 10 different units. You must have done a risk assessment as to what the risk that your proposals will actually, you agree with us that they will damage care, or you've done a contrary assessment that you think it will improve care. Can you point out where you think we are wrong?
So to start with your first point, Richard, people here will recall that absolutely the ambition was to look at how things could work on a network basis, and what transpired from that was that we didn't get proposals from providers working together that across the country gave us a satisfactory solution. So you're right, that was the first ambition that we had in terms of how that be delivered. And in terms of your point about closing units, we have no ambition to close units, our ideal is that providers all meet the standards and therefore we're able to commission all of them. The proposals reflect where providers are against that assessment. In terms of risk, part of what we do through the programme board, which is a bit of NHS England structure which oversees sort of day-to-day work around the review, is we have done risk assessment. We have a risk register which highlights a range of concerns about the potential impact. Some of those are around the risk of doing nothing, where we think services are not able to deliver the standards in the way that we would like, and that others are what the impact would be of, as you say, in this instance, if the Brompton were no longer to provide a service, where those patients would be treated. So we are far from believing that leaving things as they are now is risk-free. We also accept that there's risk attached with change, and that absolutely will be reflected in the advice and assessment that goes to the board before it makes its final decision. It's a comprehensive view of risk.
Okay, so I mean, the risk assessment has not been assessed, but has not been shared. The on a related issue, the impact on paediatric intensive care provision and the paediatric respiratory services. You said at the consultation before and in the document that this is beyond the remit of the expert group and that will be looked at in due course. How can you put forward these proposals knowing that the absolute result of your proposals that you're putting to the public is the closure of the paediatric intensive care and the paediatric respiratory services here, and not even acknowledge that in the public consultation? Isn't that being disingenuous with the public?
So I've been very clear in public meetings. I need to check the exact text of the document, but we've been very clear that we accept and acknowledge that if these proposals went ahead, that clearly would require the closure of a paediatric intensive care service, the great majority of which is CHD activity. We've also acknowledged the point from the Trust in relation to paediatric respiratory. The detail of that we would still need to do further work with you on, and Sue might want to comment on that in a moment. But on paediatric intensive care, you'll be aware, colleagues here will be aware of the parallel piece of work around paediatric intensive care across the country, the preliminary demand capacity findings of which are about to be shared, which looks at a number of issues, including the interface with CHD services. So paediatric intensive care is being looked at and will be publicly considered within that. Do you want to say something on the paediatric respiratory point?
Yes, so as part of our commissioning intentions for this year, NHS England set out that we'll be undertaking a review in London of cystic fibrosis services, adult and paediatric. So that work is in the preliminary stages at the moment, and that will continue during this year. But, you know, the congenital heart piece of work is a consultation. No decisions have been made. That is a separate piece of work that will be going on to understand the impact of cystic fibrosis services across London, not just at this trust. London and the South East.
Just to come back and point, I mean, you may feel that NHS England, you can separate these into separate little pots and things. They are completely interlinked and completely interdependent in a trust like ours. We have to deal with patients for all of this spectrum of disease. You might want to ask some of the staff how they're handling the inquiries or what you expect them to tell patients who are asking them, where am I going to go, where am I going to be cared for? Take silence as they have no answer.
Yeah. I know Dr. Rosenthal has a question, and Dr. Carvalho as well. So can we do Mark, and then Jeremy, and then Anne? Is that all right, Anne? You're still waiting on. So, sorry, right at the back over far side.
Hello, my name is Mark Rosenthal. I'm a respiratory paediatrician, and I'm not actually going to ask a question about respiratory, but following on from the proposed closure of the paediatric intensive care unit, I'm sure you're aware that it is reported by the director, or it is reported that the director of Great Ormond Street's intensive care services is telling new staff that the medium-term plan of GOS is to close their PICU to outside referrals so that they can accommodate the Brompton's congenital heart service. Therefore, the closing of both paediatric intensive care units would have a severe impact on PICU services nationwide. Do you think that's a good idea?
So we've been very clear throughout that any paediatric intensive care beds that closed as a result of these proposals would be covered off by equivalent increase in capacity elsewhere to pick that up. I can't comment on something that's been said reportedly by...
But if you close both intensive care units, that's an incredibly expensive and bureaucratic way of improving services, which I'm sure you would agree.
We are, as we've been saying, looking at paediatric intensive care in the round across the country at the moment. What currently happens in different paediatric intensive care units and how that could look different in the future is part of that discussion. I absolutely accept that demand the capacity within that and making sure that there is enough provision for children to be treated in paediatric intensive care.
But would you say that a reduction of about 25% of England's PICU beds is a good idea?
We're not proposing a reduction of 25% in England's PICU beds.
But that would be the outcome of your proposals.
Absolutely, it would not. What we are proposing is that PICU capacity that closed would be replaced by additional PICU capacity elsewhere.
If Great Ormond Street, the premier children's hospital, is proposing to close their PICU unit to outsiders, where do you propose it goes?
So within London, the additional capacity would be for children would be at Evelina and at Great Ormond Street.
I feel for you.
Should we move on? Sorry, we've already heard from you, Delaney. I will come back to you. Anne, do you still have a question you wanted to put? Well, let's get the microphone over to you. Sorry, Mark, I'm making this a bit of an obstacle course for you.
Yeah, my concern is you've come to meet with obviously a very well-informed group to start with. So I would have expected before coming here you were not only very familiar with the standards you're talking about, but you would also have the answers to the questions that are being asked. I would like to say to you now, because I feel you're hiding behind the word standards, do you have an opinion? You are here as professionals, do you have an opinion and do you really believe that this is right, honestly?
Mm-hmm. So, I absolutely believe that the standards that we're trying to implement are ones that define a good service, and I personally believe that, yes.
Thank you, and then I will come back to Julian because you've been very patient.
I think standard is like, it's a new rhetoric, it's like fake news. My question, I have a small question and then a bigger one. Do you have facts on what percentage of children require gastro service?
I don't have them here, but
okay. Does anyone in NHS England has it, apart from me? Ours is the only centre which has audited this practice, and no other centres has ever done it. Okay. Do you have any data on other centres?
I don't have it.
Okay. No. So let me give you the data. Yeah. Okay. So it is less than 1% of our children require emergency gastro services. Less than 1%. Now, my second question is, do you have any data on how many children born with congenital heart disease go on to require adult congenital heart service?
Again, we would have that. I don't have that with me.
Okay, so Brompton is the best place to give you that data.
Excellent.
Okay, so it's more than 90%.
Mm-hmm.
So now tell me what standard you are referring to. Is it not time to scratch it off, take it off, renegotiate, and then go back to the standard which Pediatric Intensive Care Society until 2015 had it in place and it works well? Okay? You can't just create a new standard and stick to it. If it doesn't make sense, get rid of it.
Do you want to make a further response?
Yeah, I mean, I hear the points made earlier on about how people in the room understandably feel very strongly about the proposal and the approach we're making. All I would say is we are absolutely keen to hear alternative views about how we make sure that these services are delivered.
Thank you.
Julian.
Hi. I would like to say how frustrated I am sitting here today, because this is meant to be a question and answer exercise, and I heard numerous questions, but all the answers I have, yes, you do a good job on this, but colocation. Yes, you do a good job on this, but colocation, but you still don't expand on that. And I must admire and congratulate you for actually having the courage to come here, to face us. Because if this were an interview panel that we're sitting at, and we're asking questions to the interviewee, and hearing the answers you're giving, me in a panel, I would have thought, this person hasn't done his homework. He hasn't come here with the answers. How can I appoint this person to whatever job it is? I haven't heard the answers to the questions. I have not heard the answers. And you're saying that we haven't made a decision, this is a consultation. Well, it doesn't sound like that. When you say the whole time, yes, but you're hiding behind that, the colocation. You still haven't answered my question, which was the second here. Why is the colocation being used as an excuse to close the Brompton? If you're hiding yourself behind that standard, why are you not using that standard against the other trusts? Why selectively doing this? This is bias. This is predetermined, pre-decided. This doesn't sound like a consultation. It sounds like we're doing this. Whatever you say, we already made a decision.
I'm sorry that's how you feel. All I can say is that this is absolutely not predetermined. What the decisions will be taken, as I say, by the NHS England board, the meeting held in public. What we do want to understand is the concerns and issues which have been well articulated today about what we are proposing. We are applying those standards to all providers. If we are clear that providers anywhere in the country aren't meeting certain standards, that is something that we need to address in our proposals, and clearly decisions need to be taken ultimately on outcome consultation which reflect where each provider is at. There's no agenda within NHS England in relation to the Brompton. We want to make sure that what we're looking to do is make sure that we've got consistent delivery across the country.
Good luck.
Thank you.
So we've heard a bit about where the services will go, but not how those services will be provided. One of the key things we've heard about here, this hostel's biggest strength is its staff. And whilst I speak from my own specialist group, cardiac physiologist, I'm sure it applies to lots of other teams. There's an assumption that we would just pick up the staff from here and put them somewhere else to provide the same services. But the reality is, outside of London, we're a highly valued asset, and there are a gazillion of opportunities for us, either in industry or in the private sector or just plain up north. But essentially, what plans have you got to provide these services, assuming you build the space, whatever? How are you going to provide the services if you haven't got that key thing, a highly specialist workforce, when it's a nationally recognised problem that there plain are not enough cardiac physiologists to go round, and people like myself, frankly, we are worth a lot, and frankly, there's not a single member of my team has plans to move anywhere other than here. It's not, it sounds like, if you move us, we'll just threaten to go. It's not that simple. We value where we are and the job that we do, and we know that we do a good job, but frankly, give us a choice about whether we do this job here or do another job somewhere else. That job will not be at Evelina or at GOS, because we're worth more than that.
So Richard already posed a question about risk, and probably among the highest risks identified is exactly that thing about staffing. So it applies absolutely in your specialty around cardiac physiology. It applies to a wide range of different areas. And I know that the Trust has identified the number of staff who would be affected internally as part of the impact assessment they've done with us. We have put that to each of the providers under our modelling, and obviously people would have choice over where they went, but under our modelling where we assume patients would go, and providers have described what they would do to be able to staff up to deliver the additional capacity required. It is absolutely this down to the individual people and their skills and their choices, so that's not within our control, but it would be the responsibility, and the discussion we'd have would be with the providers about how they would do that. But I accept it's a challenge. Absolutely.
With that, I refer you to this piece of work by the British Cardiac Society on workforce and the requirement.
Vicky, your comment won't be picked up on the microphone. Can we move on, Libby?
Hi, I'm Libby Haxby, Lead Clinician in Chorus. Just sort of take back to the comment you made earlier, that you said you believe the standards would provide a good standard of care. We don't believe in good, we believe in outstanding, and that's what we consistently deliver in this organisation. There is research in congenital cardiac surgery that shows if you want to move or replicate a service, you can't just cherry pick certain bits of it, you have to take the whole thing and replicate the whole thing. And that's not part of your plan. So I'm not very clear at all how you believe that your current plans and standards are going to improve the services that's provided to children with congenital heart disease.
So focusing specifically on the children aspect, that would be because our view is that having those services delivered in providers that are able to offer a full range of paediatric colocation is a benefit. So that's how we would see it develop. I think your other point about good to outstanding, I also made the point about sustainable services. So there is an issue, we just touched on workforce, but there are other issues in terms of how we make sure that services are robust for the future. But I accept that we don't just want services to be good, we absolutely want services to be outstanding, and I didn't mean to imply that the extent of our ambition was things to be good, but that there should be a service across the country which meets very high standards.
Piers, you had a question earlier on, you still sorry. No, just hear the gentleman who's insisted on standing up.
Well, I'm a long way back. Oh, sorry, that's a bit loud. Good afternoon, Will. Good afternoon, Sue. Thanks for coming. My question is, how on earth can this be a genuine consultation exercise? This morning I trawled through a whole number of government and solicitors' websites to see what the definition of a genuine, appropriate public consultation should be. And two principles leapt out. First of all, fairness, especially when you're depriving someone of an existing benefit. And then secondly, proportionality. Proportionality in terms of the scale, the depth of the consultation relative to the potential impact. So let's keep those in mind if we just look at the consultation documents you propose. They contain absolutely no evidence to support your assertion that this plan would improve CHD care. It provides absolutely no evidence of any risk assessment of how the plans might negatively affect patients. There's absolutely no information whatsoever on the risks involved in the adult-only model that you've proposed. There's absolutely no detail whatsoever on the impact on respiratory patients or how you would mitigate that. There's no detail whatsoever, as Mike said earlier, about the impact on CHD research. It's simply not good enough for you to say that the purpose of the consultation is to find all of this information out. You need to be providing this information in advance. You need to have dug it all out, and you need to have presented it so that everybody can be aware of it and start to think about it before you put it to public consultation. It cannot be, picking up my 2 words early on, it cannot be fair to patients and our staff that you haven't even considered many of those issues that I've just listed, and it cannot be proportionate that you have provided so little evidence, both in support of and against those proposals. So I ask you again, in the light of all of this, how can you say that this is a genuine and appropriate consultation?
So I'm very happy to say that I consider it to be a fair and genuine consultation. It's absolutely true that the core document doesn't contain every piece of detail, but we have, throughout the process of developing and agreeing the standards, and subsequently throughout the work of the review, and while we are now in consultation, put a huge amount of information on our website that includes the impact assessment, which highlights concerns that have been raised by the Brompton and other providers about our proposals, our view around how those could be dealt with. Your point about proportionality, absolutely. This is back to the consequential impact of these proposals going forward, as well as the point about there being, in the instance of the Brompton, fortunately only one standard where we have a concern. So the decision that will be taken at the end of consultation, the decisions that will be taken at the end of consultation, absolutely need to bear those things in mind, but I am entirely comfortable that what we are doing is a genuine consultation, the outcome of which may be different from what is proposed in the document.
Hello, hi, my name is Angela Aramburo. I'm a pediatric intensivist consultant, and I think you clearly would pick that I'm not British from my accent, but that's why, I'm not only very frustrated today, I'm also extremely sad to hear and realize how let me rephrase this sentence. So I would think that you and me work with the same objective, which is to provide the best care for the public. You and I work for the national health system, and I think we should all be on the same page and on that, and we should utilize the resources which are scarce in the best interest of the public, who actually pay our salaries. I'm not sure if you are aware of a publication in 2014, Lancet, which reviewed the child mortality across Europe. The UK, unfortunately, has the highest child mortality of all European countries. Highest rate of asthma deaths, highest rate of stillbirths. On the contrary, in congenital heart disease, we excel, and that's actually why I moved to this country. And we have, across the UK, above 98% survival rate for congenital heart disease in children. Do you really think, and can you justify to the public, that all this money is going to be wasted in dismantling a service that is fantastic, and it's not going to be put into really where the money is needed for, to improve child mortality in the UK?
So absolutely, I agree. I'm sure we have a common objective around improving healthcare and outcomes for children, and I chair the Women and Children's Programme Care Board for NHS England, which looks not just at congenital heart disease services, but a wide range of services and indeed with my Healthy London Partnership hat on, we're also looking at work we can do around asthma as well as a concern. I accept that we need to use the money as well as possible in order to deliver the best possible outcomes. What our view as NHS England is the best demonstration of that is how we can get services to be meeting the requirements that we're setting.
Well, I think if we would be a private company that needs to actually prove that it's being run in an efficient way with best outcomes, with the best resources being spent, I think we will clearly fail. This is basically wasting money and energy.
Thanks, Andrew. We're into the last few minutes of the session. There's a question down here and then one over in this corner. So can we start? Sorry, Mark. Getting fit, if nothing else.
Hi, my name is Hilary. I'm a performance information analyst, and mine is not a question. It's actually a suggestion, and this is based on the responses of the gentleman that was talking about data and what the stats say on congenital heart disease. May I just suggest that you look into the data again, because clearly your responses were vague, and I don't think you have fully looked into the data that you have available to you. Thank you.
Can I just respond by saying, so part of today and part of the consultation is about you coming up with suggestions, and we very much want to hear all of those views, so please submit those suggestions to us. And we'll look at
Victoria there, and then
Hi, Will and Sue. My name is Victoria. I'm one of the paediatric ITU consultants as well. So a suggestion: if everything that we've been talking about that is excellent about the Brompton is willing to be sacrificed based on this one standard of colocation of paediatric gastroenterology services, if we employ a paediatric gastroenterologist for 10 PAs a week, one gastroenterologist to sit in an office in the Brompton, to come to our MDTs every morning, to come on a ward round at 7:30 every day, is that enough?
So, the standard is 24/7 availability of that service on a co-located basis. So one 10 PA consultant would not deliver that, no.
How many would we need?
We set out really clearly in the standards, which the Trust is very familiar with, the detail of what is required to deliver the paediatric co-location.
Would you mind just telling us?
To confirm the detail of it, I'm more than happy to do that outside this meeting. I haven't got in front of me a copy of the standards.
Can we get the microphone down to Bob in the corner?
Okay, well, I'm Bob Bell, by the way.
We all know who you are, Bob.
Well, thank you. Well, you know, somebody said to you earlier that you were brave to come here today, and I think you should have known, and you probably did know, that you're not going to have an easy time. And that is because, as you heard, we have no faith, we do not believe, we do not subscribe, we do not agree with everything you're doing or saying. And that is a problem in public consultations, because public consultations have to be based on an element of shared understanding between parties, that whatever they say will be heard. And today, there's an ample evidence that whatever was said to you, you may have heard it, but we're not confident that NHS England hears it. And that's what we're asking from you, because this whole thing feels like a bureaucratic vandalism. That's not what I want you to do. The reality is, we are a caring place, we are an experienced place, We're an advanced centre. We're a highly respected place by families and patients, number one, and certainly by other professionals around the world. We want to continue to make a contribution to save the lives of these children who grow to become adults that require our services. And it is not about whether we are a level 1 or a level 2 nonsense. It's absolute nonsense, and you know that. What we are about is that we are a major contributor to what happens in the world of congenital heart disease. And what we want to see is not a standard. We want to see an understanding from NHS England that probably your process was wrong. And that's why we do not agree with you. And that's why we would like to see a change. Now, I'm not asking you today to make a comment. We've known each other for many years, and I know you are here to do a job, and we respect that. But what I'm asking you is, through your colleagues, get these messages up to the people that really care. Because either the messages go back through you, or we will find the means to get the messages to people who really care. I'm asking everyone in this room to now, after today, not feel that they've said their piece, but to go and fill out the consultation forms, because I know paper matters, and you should. Don't feel that what you've said today has been just heard and recorded. You need to be registering what you said on paper and feed it into the system. I want to make sure that your bosses understand that we're not going to take this lying down. And we don't need to have a fight on our hands. What we need is to find a way to work together to achieve the results or the objectives that you have in mind for the better of patients. We had 2,000 people march on the streets of Chelsea 2 weekends ago. Now, I know you don't live in Chelsea. I live around here. That is an exceptional event. This is not what happens on the King's Road on a Saturday morning. And Bruce Keogh and friends need to hear that and understand that that is what's needed, is through your consultation process, you've seen the anger, you've heard the hurt, the indignation, the disbelief that is really present by people who are high professionals that we know we can lose easily in this country, and we don't want to lose, because many of the people that are here are not just from this country, they're from around the world, including me. And we come here because this place provides us with the environment in which we can contribute to the NHS, the values that the NHS needs, because this is the place. And now you come along, or somebody does, a committee, bureaucratic vandals, and wants to destroy it. It will not be acceptable, because we have a voice, we have a say, and we speak on behalf of patients. So I don't expect an answer from you. Don't give me one, but I just want us to close on that note. We want to work with you.
Thanks, Paul.
We've overrun by a few minutes. That we should call a halt. Will, Sue, is there anything else you would like to say before we close?
I'll just echo Bob's point about really encouraging people here and colleagues in the Brompton and others to respond to the consultation. It's really important that people have the opportunity to have those views put forward, which will be analysed by an independent company, not by NHS England, to say what the responses have been.
I'd like to just thank everyone for taking the time to come today and share those views. It's really helpful for us to hear it firsthand from you guys, and clearly your passion and commitment to the service comes across, so thank you.
And we'd like to thank you for coming. One or two people have said it, but thank you for taking the time to sit in front of the audience and listen to what we've had to say. Thank you, both of you. Thanks for your time this afternoon.